PCOS or Polycystic Ovary Syndrome is one of the most common hormonal disorders affecting women of reproductive age, yet, nearly 70% of the cases remain undiagnosed. In this, we will simplify the clinical reasoning behind PCOS and understand how hormonal imbalance, insulin resistance, lifestyle, and nutrition all connect together. Did you know around 1 in 5 Indian women may be affected by PCOS, making it a major public health concern and one of the leading causes of infertility? In this lecture, we will cover all the high yield concepts of MBBS students and NEET PG aspirants that they must know, including the pathophysiology of PCOS, common symptoms, diagnostic criteria, and evidence based management strategies. We will also discuss why lifestyle modification remains the cornerstone of the treatment, how targeted nutrition improves insulin sensitivity, and which medications are commonly used in clinical practice. Whether you are preparing for exams or building stronger clinical concepts, this session will help you approach PCOS in a structured and simplified way. Let's begin. Meet Priya, our patient for today's clinical discussion. Priya Mehta is a 24-year-old software engineer from Pune who presents with irregular menstrual cycles for past 8 months. On examination, her weight is 72 kilograms with a BMI of 24.4, placing her in the overweight category. When we look deeper into her history, several classic red flags appear. She reports oligomenorrhea with menstrual cycles occurring every 45 to 90 days. She has also noticed increasing facial acne and excess facial hair growth, suggesting hyperandrogenism. Despite maintaining a moderate diet, Priya complains of gradual weight gain along with fatigue and mood swings affecting her daily life. Now, pause and think clinically. A young woman with irregular periods, weight gain, acne, and hirsutism, what endocrine disorders immediately comes to your mind? This is a classic presentation of PCOS, Polycystic Ovary Syndrome. But before jumping to conclusions, let's systemically analyze the underlying hormonal disturbances and diagnostic criteria step by step. Now, let's look at the Priya's investigations and see whether the objective evidence supports our clinical suspicion of PCOS. First, notice the LH to FSH ratio. Our ratio is 3.2 is to 1, which is significantly elevated above the normal value of less than 2. This occurs because increased LH stimulation in the PCOS promotes excess androgen production by the ovarian theca cells. Next, look at the testosterone level. Priya's serum testosterone is mildly elevated at 72 nanograms per deciliter, supporting biochemical hyperandrogenism, one of the hallmark features of PCOS. Now comes one of the most important concepts in modern PCOS understanding, insulin resistance. Her fasting insulin level is 18 milli international units per liter, which is clearly elevated. Remember this high yield point for exams. Hyperinsulinemia increases ovarian androgen synthesis and worsens the anovulation, weight gain, and metabolic dysfunction. Finally, the pelvic ultrasound shows 12 to more follicles per ovary. The classic polycystic ovarian morphology often described as the string of pearls appearance. So, when we combine irregular ovulation, clinical and biochemical hyperandrogenism, and polycystic ovaries on ultrasound, Priya fulfills the diagnostic criteria for PCOS. But the real question is, what is the underlying hormonal mechanism driving all these abnormalities? Let's break down the pathophysiology step by step. Now comes the clinical dilemma. Priya asks an important question. Doctor, I don't want medicines right away. Can lifestyle changes alone improve my PCOS? This is a very common real world scenario and an extremely important NEET PG concept. So, what should be the best line approach? First, you can start the oral contraceptive pills immediately to regulate the menstrual cycles. Next, begin in metformin alone to target the insulin resistance. or a structured lifestyle intervention for 3 months with dietary modification, exercise, sleep correction, and regular follow up. Pause for a moment and think. In overweight women with PCOS, lifestyle modification is considered the cornerstone and the first line therapy. Why? Because even 5 to 10% reduction in body weight can significantly improve the insulin resistance, restore ovulation, regulate the menstrual cycles, and reduce the androgen levels naturally. A low glycemic index diet combined with regular physical activity directly targets the metabolic root cause of the PCOS. Now, that does not mean that medicines are never needed. Oral contraceptive pills are useful when menstrual irregularities, their acne, or hirsutism remains significant concerns. Metformin is especially beneficial in women with insulin resistance, prediabetes, or obesity. But in a motivated young patient like Priya, lifestyle intervention should be the foundation of the management. So, the best clinical approach here is lifestyle first, then the close follow up and reassessment. And this is one of the most tested concepts in exams. Lifestyle modification is first line therapy in overweight PCOS patients. Let's understand why starting oral contraceptive pills immediately is not the best first step when used alone. Many clinicians are tempted to prescribe OCPs early in the PCOS management. Why? Because they work fast. They quickly regulate the menstrual cycles, reduce androgen levels, improve acne, and decrease hirsutism. From the patient's perspective, symptoms appear better within a short time, creating the impression that the disease has been fixed. But here's the critical clinical insight. OCPs mainly suppress the symptoms, they do not correct the underlying metabolic problem driving PCOS. And that root problem in many patients is insulin resistance. If we only mask symptoms without addressing the weight, diet, physical inactivity, sleep, and metabolic dysfunction, the hormonal imbalance often returns once the pills are stopped. In some patients, certain OCP formulations may even worsen weight gain or metabolic risk factors. This creates a long term problem. The opportunity for early metabolic corrections gets missed. That's why current clinical guidelines emphasize lifestyle intervention as the foundation of therapy, especially in overweight women with newly diagnosed PCOS. Now, remember this important example: OCPs are excellent for symptom control, but lifestyle modification treats the disease process itself. And that distinction is extremely important in both exams and real clinical practice. The real pathophysiology behind PCOS, the vicious hormonal cycle, every MBBS and NEET student must understand. It usually begins with insulin resistance. The body cells stop responding properly to the insulin, so insulin levels rise, what we call as hyperinsulinemia. High insulin then overstimulates the ovaries and increases the LH activity, leading to an ovulated and elevated LH to FSH ratio. This hormone imbalance drives excess androgen production, especially testosterone. That's why patients develop acne, hirsutism, and scalp hair thinning. The excess androgens interfere with normal ovulation, causing anovulation and multiple immature follicles, which appear as cysts on ultrasound. And because ovulation is disrupted, weight gain and metabolic dysfunction worsen further, feeding back into more insulin resistance. So the cycle keeps reinforcing itself. Insulin resistance, then LH surge, then androgen excess, then anovulation, then worsening the weight gain, and back to insulin resistance again. This is exactly where lifestyle intervention is true foundation of PCOS management, because if you break insulin resistance early, you can interrupt the entire cycle. And this is why option B, lifestyle intervention first, is the best initial approach for Priya. Notice what happens when we target insulin resistance directly. A low glycemic index diet, regular exercise, better sleep, and even modest weight loss improve insulin sensitivity. As insulin levels fall, the abnormal LH stimulation also starts reducing. That means the ovaries produce less excess testosterone, and when androgen levels fall, ovulation gradually begins to normalize again. The menstrual cycles improve naturally, not artificially. Even a small weight loss of just 5 to 10% can significantly improve ovulation, fertility, acne, and metabolic health in PCOS patients. So, lifestyle management is not a general advice, it is actually a targeted metabolic treatment that attacks the root cause of PCOS. This is the key exam concept. OCPs control symptoms temporarily. Lifestyle intervention modifies disease progression itself. That's why, in overweight women with early PCOS who are motivated for non pharmacological management, lifestyle modification is considered the true first line foundation therapy. So, what exactly should be proper PCOS lifestyle prescription look like? Here's a simple 90-day protocol that targets the metabolic root of the disease. First is nutrition. The goal is to reduce the insulin spikes. Patients should not avoid refined sugars, maida, sugary drinks, and ultra processed foods. Instead, focus on low glycemic index, high fiber meals using complex carbohydrates like brown rice, ragi, oats, dalia, vegetables, and protein rich foods. Second, exercise. This is a non negotiable in PCOS management. At least 150 minutes of moderate aerobic activity per week combined with resistance training twice daily significantly improves the insulin sensitivity. And remember, even a 5% reduction in body weight can restore ovulation in many women with PCOS. Third, the sleep and stress control. Poor sleep increases cortisol, which can worsen androgen excess and metabolic dysfunction. That's why 7 to 8 hours of quality sleep, along with yoga, mindfulness, and stress reduction techniques, can actually help normalize the hormonal regulation. And finally, where does metformin fit in? Metformin is considered an adjunct, not the first line treatment in most early PCOS cases. It is especially useful when BMI is about 25, insulin resistance is significant, or lifestyle measures alone are insufficient. So, the real treatment strategy is lifestyle first, medication only when needed as supportive therapy. That's the evidence based long term approach to PCOS management. Let's make this practical with an India specific PCOS nutrition guide. The main goal is simple: reduce the insulin spikes, improve hormonal balance, and support the sustainable weight loss. So, what should the patients eat more of? Start with complex carbohydrates like ragi, jowar, and bajra. These have a lower glycemic index compared to refined wheat or white rice, so they release glucose more slowly. Next, protein. Foods like moong dal, chana, rajma, paneer in moderation, eggs and curd help improve the safety and stabilize the blood sugar. Micronutrient rich foods are also important. Leafy greens, bitter gourd vegetables, and antioxidant rich foods help reduce inflammation linked with PCOS. Healthy fats matter too. Almonds, walnuts, flax seeds, and seeds rich in omega 3 fatty acids may help reduce the androgen related inflammation. Now, what should be avoided or limited? Simple carbs like maida, white bread, bakery items, and excess white rice can worsen insulin resistance. Processed foods like packaged biscuits, namkeen, chips, fast food can increase the calorie load without nutritional benefit. Sugary chai, cold drinks, and sweetened beverages create rapid insulin spikes, which is one of the biggest metabolic triggers in PCOS. And very important lifestyle habit: avoid late night eating and irregular meal timing because circadian disruption worsens insulin resistance. The key message for patients in this is PCOS diets are not crash diets, they are long term metabolic correction strategies. Small, sustainable dietary changes consistently outperform extreme short term dieting. Targeted supplementation, enhancing the protocol. Now, let's talk about the targeted supplementation in PCOS management. These are not magic cures, but when combined with lifestyle correction, they can significantly improve the metabolic and hormonal balance. First, inositol, especially myoinositol and D-chiroinositol, improves the ovarian insulin signaling and may help restore the ovulation in many women with PCOS. Next is vitamin D3. Vitamin D deficiency is extremely common in Indian women and is strongly associated with the insulin resistance and hormonal dysfunction. Correcting the deficiency can improve overall metabolic health. Next is omega 3 fatty acids, which help reduce the systemic inflammation, plays a major role in worsening the insulin resistance and androgen excess. Then comes the magnesium, which supports glucose metabolism, improves insulin sensitivity, and also helps with sleep quality and stress regulation. Next is N-acetylcysteine, which acts as an antioxidant and may support ovulation and egg quality, especially in women planning pregnancy. Finally, zinc, that can help reduce acne and hirsutism by supporting the androgen regulation. But remember, supplements are supportive tools, they are not the substitutes for nutrition, exercise, sleep, and weight management. The real foundation of PCOS treatment is metabolic correction through lifestyle change. Let's finish with some high yield clinical polls that are extremely important for NEET PG and clinical practice. First, remember the Rotterdam criteria for diagnosing PCOS. A patient requires two out of these three features: 1. Oligo or anovulation, meaning irregular or absent ovulation. Second, clinical or biochemical hyperandrogenism, such as acne, hirsutism, or elevated testosterone. And third, polycystic ovarian morphology on ultrasound. Now look at this classic NEET PG scenario. A young obese woman presents with oligomenorrhea, hirsutism, and bilateral polycystic ovaries on ultrasound with an elevated LH to FSH ratio. What is the most appropriate first line management? The answer is lifestyle modification with weight reduction. This is the key concept many students miss. Before jumping to medications, the first and most evidence based intervention is overweight PCOS patients is targeted lifestyle correction. Another example for ovulation induction is infertility associated with PCOS. Letrozole is now preferred over clomiphene citrate because it has better ovulation outcomes and lower risk of multiple pregnancy. And finally, remember the role of metformin. Metformin is mainly an adjunct for insulin resistance. It is not the universal first line treatment for every PCOS patient, especially not in a lean PCOS without metabolic dysfunction. So, the take home message is simple: PCOS is fundamentally a metabolic endocrine disorder, and lifestyle intervention remains the foundation of the management. The ultimate takeaway. So, what's the ultimate takeaway from this case? PCOS is not just a gynecological disorder, it is a metabolic and hormonal condition that affects the entire body. And while PCOS may not have a permanent cure, it can absolutely be controlled with the right long term approach. The most powerful treatment does not begin in the pharmacy. It begins with the lifestyle. A balanced, low GI diet, regular exercise, quality sleep, stress control, and sustainable weight management can dramatically improve the insulin resistance, restore the ovulation, and reduce the androgen excess, and also improves the long term health outcomes. Medication can support the process, but they work best when the metabolic foundation is corrected first. So remember this line: lifestyle is the prescription, diet is the medicine, and consistency is the renal cure. Thank you for watching this PCOS simplified session. I hope this case based discussion helped you understand not just the diagnosis but the real clinical reasoning behind the PCOS management. If you are an MBBS student, NEET PG aspirant, or healthcare learner, make sure you follow for more high yield clinical cases, simplified concepts, and exam oriented and focused learning. Don't forget to like, share, and comment your biggest takeaway from today's session. And remember, medicine becomes easier when you understand the why behind the disease. See you in the next lecture. Thank you.